Good morning, everyone present here. I'm delighted to welcome you all for this national webinar on bleeding in early pregnancy and its management. Before we start the ball rolling, let me give you a few instructions for smooth attending of the webinar. The instructions for attending the webinar: please keep your video and audio mute. Please off them before joining the meeting, and all the queries that has to be posted in the chat box. Each certificate will be awarded after filling the feedback form, which is open after the webinar for 24 hours, and you will be receiving the e-certificate within 1 week after the webinar. So, on behalf of OBG Department of Apollo College of Nursing, I, Harika Priyanka, Assistant Professor, would actually relish the opportunity of being your host for today's webinar. It's a great entitlement to have expertise speakers to share their knowledge with us today. But before that, I would like to give a brief introduction on our topic. So, this early pregnancy loss or miscarriage is a common phenomenon in pregnancy. The spontaneous loss of a pregnancy before 13 weeks of gestation, which is a devastating problem for women who lose a highly desired pregnancy. There are so many treatments available, and various treatment modalities are available all over the world, which are used to assist the women who have experienced early pregnancy loss. So here, the role of the nurse or the midwife is very crucial in providing care to the midwife when it comes to resolve herself and also carry out further pregnancies. So the early bleeding in pregnancy includes abortion, ectopic pregnancy, highlighted for mole, subchorionic hemorrhage, and few other conditions. So never taking much of your time, now let me request our principal, Dr. T. Vasundhara Tulasi ma'am, to inaugurate the webinar. On to you, ma'am.
Miss Harika, if there is any possibility, can you mute all except host from there? It's giving a lot of disturbance. If there is any possibility except host, please mute everyone. Hi, welcome everyone. Thank you for joining us for today's webinar. I, Dr. T. Vasundhara Tulasi, take the privilege of inaugurating this webinar for today. Apollo is one of the leading nursing colleges in the state of Telangana. While Apollo Hospitals, a pioneer in the patient care services in India and abroad, we work under the eminent leadership, guidance and blessings of our beloved chairman and patron, Padma Vibhushan Sri Dr. Sri Pratap C. Reddy Garu, and his 4 daughters, namely Preeta ma'am, Sunita ma'am, Sangeeta ma'am, and Shobna ma'am. Well, we have planned weekly webinars from various departments of nursing at Apollo College of Nursing as part of our professional and social responsibility during the period of COVID. I strongly believe that today's webinar will be an enriching experience as we have eminent speakers for today. Dr. Jubilee Gnanathia, HOD of OBG Department, and she has been associated with Apollo College of Nursing for the past 8 years. She is known for her simplicity yet hardworking and tries to bring best out of the students in the field of midwifery. I congratulate Jabila and her entire OBG team for selecting today's topic, that is on management of bleeding in early pregnancy. It is believed that 15 to 20% of women would experience bleeding in early pregnancy, but most of them result in healthy babies. Yet we need to be considerate as it could be a sign of complication like miscarriage, ectopic pregnancy, placenta previa, which cannot be ignored. Let us all now get reoriented from our experts for today. Now I request Ms. Harika Priyanka, Assistant Professor and SNA Advisor at Apollo College of Nursing, to lead the program and webinar as moderator. Over to you, Ms. Harika.
Thank you, ma'am. Now, we know the disorders of bleeding in early pregnancy. I think it's even more mandatory to know the diagnostic and treatment modalities. So now it's time to start a diagnostic and therapeutic management, which is shared by one of the esteemed and renowned speakers, Dr. Krishna Kumari Madam. I feel so honored to familiarize to you all, dear attendees, for the day. Dr. M. Krishna Kumari Ma'am, who holds H.M. Lazarus Gold Medal in MD and also a scientific chairperson of FOGSI-FIGO International Congress on Clinical Challenges in Obstetrics and Gynecology 2017. Ma'am is a Vice President of Telangana Congress of Obstetrician and Gynecology. Ma'am is a Governing Council member, ICOG, from 2018 to 21. Ma'am is a Senior Consultant at Medicover Women and Children Hospitals, Hyderabad. Ma'am is a teacher at Medversity College of Physiotherapy, and now Ma'am is working as a professor at Apollo IMSR, Hyderabad. Good morning, dear Ma'am. I welcome you to the webinar. I request you to please start the topic, Ma'am.
Yeah. Good morning. Can I share? Can I don't know. I'm seeing somebody else on this thing.
Ma'am, you are visible, ma'am.
Okay. So now I will thank you all for your very kind welcome, and it's a pleasure spending this morning with you all. I think that during this I don't know about the nursing staff, how much you have an onslaught, but really in our obstetrics and gynec department, we are really having an onslaught of webinars. So how much of this, I mean, how frequently you're going through all this, I have absolutely no idea, but still it is a real pleasure for me to be there with you all today morning and share the therapeutic and diagnostic aspects of early bleeding, early pregnancy bleeding. So I think the speaker before me has done an exhaustive and introduction to and an overview. I think she has covered even the diagnostic and therapeutic parts of it. So she has made my job very easy. But I would like to tell you all that some of the slides would now be maybe a little repetitive. Okay. Can you visualize me right now? My slides?
Yes, ma'am. Can you put it? Yeah, ma'am. It's fine, ma'am. Now.
Okay.
It's visible.
Okay. So I don't know. I cannot see anything except my slides. So let's go ahead like this. And I think I request once again all the other participants to just mute your computer so that the noise is very disturbing, the background noises. And the other thing is, any questions, you please post them on the chat. I think there should be a chat column. I'll take them up at the end of the session, and or you can directly ask me after the session is over. So right now, moving on to my topic. It is diagnostic and therapeutic management of bleeding in early pregnancy. And this is just to give you all a rough idea. So let's imagine a woman that she's planning a pregnancy. Then the first event that happens is fertilization, we all know. After fertilization comes implantation. And before the pregnancy, before the embryo gets implanted, there's a 30% chance of her losing that pregnancy. So now it has got implanted. The next thing is she's going to miss a period, right? So even before she misses a period, 30% of pregnancies are lost. So much of pregnancies are lost even before she has even noticed that she has lost the pregnancy. So that is the reason why we give a wider margin of 1 year before we call it, and we take it up as a fertility issue. Now she has missed a period, we have confirmed her pregnancy. Now again she has a 10 to 15% chance of having a miscarriage. And ultimately, of the fertilized embryos, only 30% are going to land up as live births. So this is what we have to understand, and I think support women when they get frustrated within 2 to 3 cycles of pregnancy and of planning the pregnancy, they do not get get to be pregnant. So we need to understand this table first. Then coming to bleeding. So bleeding in early pregnancy is common. This is what our American College of Obstetricians and Gynecologists, the statement says it is common. So how common is it? It can be as common as 20 to 40% of pregnant women. It can be light, it can be heavy, it can be intermittent, it can be continuous, it can be associated with pain or maybe not associated with pain. Then you have the normal bleeding or so-called normal bleeding. So what is a so-called normal bleeding? It can be simple things like physiologic or implantation bleeding. So basically this implantation bleeding is by excluding other possibilities of other problems. So if at all a small amount of spotting occurs, means a very scanty bleeding, usually it is at the time when the fertilized embryo gets implanted into the and buries through the decidua. That is the time you might have some sort of bleeding. Then you can simply tell the patient, convince the patient, oh, this spotting, nothing to worry, it can just be an implantation bleeding, let us wait and watch. That is what I mean to say by introducing you to this implantation bleeding. Then there is another entity known as a decidual bleeding. So in decidual bleeding, what happens is, as you can see, there is a decidua capsularis and there is a parietalis. So it takes almost 3 months. At the end of the 3 months itself, these two get fused up and the embryo occupies the whole of the uterine cavity. Before that, there is some space available and the decidua, which is lining the uterine cavity, that is the parietalis, is free. So this will reacts to hormones, or it may shed some amount of blood during the first 3 months, because this whole thing is fused off and there is a plugging of the cervical mucus. Before that, there can be some amount of spotting. So that is what we call as decidual bleeding. So these two things happen even when when the pregnancy is normal and healthy. So next, coming to normal. So is all bleeding normal? Now we all know that normal is an illusion, and there can be many pathological conditions also which can cause this sort of bleeding other than the normal possibilities. So what are the different causes? It can be from the genital tract, it can be from the extragenital tract, it can be in the genital tract, it can be from the uterus, it can be from the vagina or from vulva too. So there are a lot of conditions. Already I think this must have been introduced to you, the number of probabilities which are there in a case where there is abnormal vaginal bleeding in early pregnancy. So, but most important thing of the uterine conditions we have to remember is that 30%, if then there is a bleeding, 30% are likely to miscarry. 10 to 15% can land up in an ectopic pregnancy, and 0.2% there can be an associated molar pregnancy. So these are the possibilities when there is a bleeding which happens in the early pregnancy. So next coming to is, let's imagine a patient who is coming to you to the emergency department. So this patient in the reproductive age, once she comes to the emergency department or your admission room or your labor room, wherever it is, wherever you see the first, wherever your first point of examination is. So first thing you have to do is identify whether, ask the question, is there possibility of she being pregnant? That is, you find out her LMP and if she has been using any contraception. These are the basic questions which should be asked for any woman who is coming to the emergency department. If she is not pregnant, then treat her like other non-pregnant women and you can go ahead with further investigation for whatever cause she has come. Now, she is found to be pregnant. Then the next important thing is you identify she is more than 20 weeks in gestation or less than that. If she is more than 20 weeks, it is not in our domain today to discuss about a gestational age more than 20 weeks. Bleeding happens also. So let us see if the gestational age is less than 20 weeks, then you ask for bleeding, pain, syncopal attacks, and then you consult with your obstetricians to find out what could be the problematic. That's the first thing. Next important thing, because you are the first person who is going to be there, definitely the emergency or the admission room or wherever it is has a nurse practitioner, a nurse there. It's very important. You have to identify whether severity of bleeding. So what you identify is she, first thing is based on the amount of blood loss that is happening. The first thing you have to identify is whether she is hemodynamically stable or hemodynamically unstable. Am I clear?
Yes, ma'am. Yes, ma'am. Yes, ma'am. You're audible, ma'am.
Okay, okay. So is she hemodynamically stable or unstable? That is what we are going to identify. So then there is a midwifery triage. That is what we are doing in the triage area. That is, first you are trying to assess the condition, assess the individual, and then deciding about the priority level for evaluation. Then you identify whether it is an emergency or a non-emergency. If it is an emergency, you have a point of care ultrasound. What's happening, ma'am? You have a point of care ultrasound. That is the easiest way to help you to diagnose, especially if the patient is, it is an emergency, patient is unstable. Then the first investigation you would like to find out is whether she is having any pathology or not. Next, what was the intervention that is first done? The first intervention that is done is you have to ensure patient safety by identifying and controlling bleeding, and if she is in shock to whatever you have to, resuscitation, that could be the first thing. Maybe putting a line, putting her on oxygen. That is what we have to do. And how do you identify this hemorrhagic shock? By increased heart rate, fall of blood pressure, cool, clammy skin, lightheadedness, confusion, and the need for oxygen therapy, fluid and blood replacement. These things have to be assessed. Then vital signs, oxygen saturation, intake, output, and lab results according to the institutional policies you have to decide. Then if there is associated infection, you have other warning signs like fever, foul smelling vaginal discharge, and she might also complain of pain in the vagina. That is what has to be assessed. Then once you have assessed the patient, the next important thing is resuscitation. So resuscitation, first thing, don't worry about calling somebody there. If the patient is coming to you in shock, first thing you need to do is urgently start her on oxygen, IV line and all. And then look at the basic investigations, whether you want to send CBC, coagulation profile, blood group, cross-matching, or the obstetrician or whichever doctor is there with you can guide you regarding the same simultaneously, especially blood group and cross-matching is very important because this patient, suppose she's an ectopic pregnancy, suppose it's a ruptured ectopic, or if it's an incomplete abortion and she's bleeding so profusely that she might be going in, she has gone into shock, then it is very important that you need to replace it. So immediately collect all this. And a simple blood side prop test also can be done for you to assess the, if there is excessive blood loss and if she's going into any DIC or coagulation disorders. Now, after that, you after detailed history, examinations, now you and investigations, you can leisurely then take up, or the obstetrician who is going to attend is going to take up all these further, and then if needed, they will plan for surgery. And then preparation of the patient for surgery as per your protocols, consent taking, documentation, all these are important issues. And parallelly, you have also addressed nutrition. If you're planning for surgery, maybe NBM. If you're not planning for surgery, maybe depending on the patient condition, oral or intravenous fluids can be taken care of. So, two major important things without where there is no trauma. Without trauma, early pregnancy, patient comes to you with bleeding. First thing you have to think of ectopic pregnancy or early pregnancy loss, which can be anything. It can be threatened, inevitable, incomplete, or complete. And an early pregnancy loss is the most common when you look at a pregnancy where there is a positive pregnancy test followed by excessive bleeding per vagina. There are certain terminologies which you should be familiar with. One of them is an embryonic gestation. Suppose there is at a particular point of time, the gestational sac is very well visualized, but you are not able to see the fetus inside it. In spite of the sac being adequate enough, then you call it as an embryonic gestation. Embryonic demise is when you see an embryo, but when you're not able to appreciate the fetal heart. For example, the patient is 7 weeks from last menstrual period, has regular cycles, but in spite of doing an ultrasound, you're not able to pick up a fetal heart. Then you know it is a embryonic demise. There is another entity known as pregnancy of unknown location. You find an pregnancy test which is positive, and the timeline of the ultrasound is not found. That means if you're not finding either a gestational sac, nor an embryo, nor a yolk sac, nothing as per the nothing inside the uterus. There is a positive pregnancy test, nothing inside the uterus. You cannot pick up an ectopic. Then we call it as a pregnancy of unknown location. Then of course, spontaneous, threatened and incomplete abortions, I think all of you know. I think the previous speaker must have introduced you to all these terminologies. Now, looking at a patient who is stable. Patient is coming to your OPD, she's stable. Then your first important thing is you have to, the most important things are in the stepwise. First, concentrate on the history. Then you will get some idea of what exactly the problem is. Then look at the physical examination, whether it is a general or a local examination. Then go for lab testing, then do for ultrasound. So these are the ones which are going to guide you in your diagnosis. When the patient is stable. So what is the history like? Patient says, I have passed blood clots, I have feeling very lightheaded, I had pain and then passed blood, small clots have passed. Most important thing you have to ask is, did you pass any tissue-like material? If she says that she has passed any tissue-like material, it can be either ectopic pregnancy because decidual cast or some amount of material where intrauterine endometrial shedding is there even in ectopic pregnancy, as well as whenever there is an early pregnancy loss. So, but then if the let's say she says I have only very light bleeding with very mild or painless bleeding and occasional spotting, still remember it can be an ectopic pregnancy. An ectopic pregnancy can present either with the normal menstruation, no menstruation, scanty intermittent bleeding. So any type of bleeding disturbances can be associated with an ectopic pregnancy. That is the basic bottom line you have to remember. Just because she said I had my normal period 1 week back, don't say there's no ectopic. She says I had a period, but the period was very light. Then also think of an ectopic. So if any woman in the reproductive age group, you always have to think of an ectopic pregnancy irrespective of the type of bleeding. So you go into the age, you find out the details of the menstrual history, then the pain and the amount of bleeding, and whether it is a spontaneously she has got this pregnancy or she has had it by assisted reproduction. Because people who have assisted reproduction are likely to have more pregnancy associated complications too. That is a high, the rate is a little higher in them. So if she's been under any contraception, some types of contraceptives will enhance the risk factors. Then previous obstetric history, like she had one previous pregnancy losses and pelvic inflammatory diseases. All these are history are important in the history. Then now you look at the patient's BMI. Then you look at the vital signs, abdominal examination. You try to look if there is any guarding, if there is any fluid in the abdominal cavity, or if the patient is having tenderness, and if the uterus is bigger than what it should be. She says, I'm 2 months pregnant, but you can palpate the uterus per abdomen. Then think of either a multiple pregnancy or a molar pregnancy or any tumors which are increasing the size of the uterus. That is what is your inference. Then you do a speculum examination if a patient is stable, and then you can find out if there is any vaginal cause of bleeding like a postcoital tear. It can be there. There can be a vaginal tumors, or there can be a cervical lesions like a polyp or an ectropion or a fibroids, or there can be including carcinoma of the cervix can be there. So on speculum, you look at all the surrounding structures and also look at the cervical os. When you're looking at the cervical os, if you find the os to be open and you can see some products looking at you through the cervical os, you know she is landing up in an incomplete abortion or an inevitable type of abortion. If she says she is passing some tissue, or you can pick up some tissue from the vagina or the cervix, be sure and go for a microscopic examination and see if it is a villous tissue or if it is just a clot. Then the next thing you have to do is do the lab investigations. In the lab investigations, the most important relevant test which is important for us in an early pregnancy is the beta HCG. So beta HCG is what we are calling a urine, simple words. It is a urine pregnancy test where we are checking for the beta HCG. So if the beta HCG is done by a simple urine pregnancy test, the test comes positive and the pregnancy is going normal. In a normal healthy pregnancy, that is enough for us. We just look at the urine pregnancy test. Okay, the pregnancy test is positive and she has no other symptoms. Then we just do the routine antenatal care which she is supposed to get. But suppose you are expecting some pathology, then you may have to do a more importantly, you have to do a blood test. That is the serum beta HCG. So serum beta HCG is positive much earlier than the urine beta HCG. It comes into the serum much earlier and it is picked up within 8 days after ovulation. That is, if ovulation is happening on day 14, then by day 23 you see some amount of beta HCG in the blood. So you can pick it up much earlier. The other important aspect of serum beta HCG is it is not only qualitative, it is also quantitative. So a qualitative test means it just urine pregnancy test just tells you if the patient is positive for pregnancy or not. But it doesn't mention to you regarding the quality of the pregnancy. So a qualitative analysis can be done by doing a serum beta HCG. For quantitative, so in this you measure the HCG levels. So what happens is, and you repeat the HCG levels. Suppose you are suspecting a non-viable intrauterine pregnancy or an ectopic pregnancy which is in the early stages, and you are giving expectant line of management, you can follow up by doing a serial beta HCG. So if the HCG levels are falling, you are happy. Suppose it is constant or it is raising, now you know that the ectopic is not responding to expected management. It needs to be surgically, or so you have to treat it in some other way. Then it rises very slowly in ectopic pregnancy, but rises very well in a viable intrauterine. Suppose there is a threatened abortion. You want to follow it up by saying whether this baby is going to be good or bad. Then you can do a repeated HCG so that you know if it is rising levels, it is going to be likely to be a viable intrauterine pregnancy. Of course, other hormonal assays are also available like progesterone, inhibins, PAP, but they are all less useful in the clinical scenarios as of now. So next comes after the lab, the next important investigation we would like to do is the ultrasound. So you have your history. Then you have your clinical examination, whether it is general examination or whether it is a local examination. Then you have done a beta HCG, and also another most important thing you need to do now is the ultrasound. So you have done an ultrasound, there is a timeline. So suppose the patient has missed a period exactly at the day of missing a period. So she just missed a period, if you do an ultrasound, the gestational age is just 4 weeks. You won't find anything except possible endometrial thickening. Then slowly a few days later, you will find the gestational sac. Then comes the yolk sac, and then the fetal pole appears. And usually, if you can do a transvaginal scan, you can pick it up fetal heartbeat also much earlier by 5.5 weeks, and sometimes as transabdominal a little later. So that is, you can pick up a transabdominal ultrasound around 6.5 weeks. So there is a timeline. So depending from LMP, suppose the patient comes to you with 5 weeks or 4 weeks at the time of what you consider as a decidual bleeding, and she says, I'm having bleeding, even if you send for a scan, you won't get any inference because you cannot see the gestational sac. Patient missed a period by 1 week, you will find a gestational sac, but you may not find a fetal pole, or a heartbeat may not be seen. So depending on when you are sending from the last menstrual period, as per the timeline, your expectation should be. And again, 4 weeks you can't, at 5 weeks you cannot send a patient within 1 week of missing a period and say there is no fetal heart or there is no fetal pole. That is a wrong interpretation. So this timeline has to be followed. So as you can see, this is how it looks. A small gestational sac just has come. Now you can see inside the gestational sac has become bigger, and you can also see a yolk sac inside the gestational sac. Then later on, you're also seeing the embryo. See here, you can see this is the fetus, and you can also measure the CRL. So this is how the timeline goes in by ultrasound as per the period of gestation. So there are certain criteria by which you can on ultrasound as per the timeline. So at certain point of time, you don't find an embryo, you find a huge gestational sac, you do not find an embryo. You have found an embryo, but even after 7 weeks, you're not finding heartbeat. Or if there is a crown rump length has already is more than 7 mm, but there is no cardiac activity. Or there is a previously existing embryo, now the whole uterine cavity is empty. So based on that, you can have some idea about what is the problem. So as you can see, there's a huge sac. I can see a gestational sac, but I cannot see any fetal pole. So this is definitely what we call as an embryonic pregnancy. Here, they have seen a fetus, but they are not able to pick up the heartbeat. That means it's such a good CRL and such a big embryo, not able to find the fetal heart rate. Maybe if there is no bleeding, I'll wait for a week and recheck again, because your instrument may not be so good, or your observer, the person who, it depends on the machine as well as the observer. But if there is a severe bleeding and this shows no heartbeat at 7 weeks, then maybe I would act. So it all depends upon the patient symptoms as well as your findings. So your findings which are suggestive that there is no unhealthy pregnancy or a not going pregnancy, but patient is not having any signs or symptoms, you can wait for some more time. If the patient is having signs and symptoms and the ultrasound is supporting your clinical probable diagnosis, then there's no point in waiting. So that is how you go about managing these cases. So I have heard the previous speaker saying about subchorionic hematomas. They are very quite common. As you can see in this picture, there's a fetus, there is a this is the amniotic sac. And you can see behind the membranes have separated the chorion, and there is a collection of blood between the uterine wall and the membrane. So this is what we call as subchorionic hematomas. And these patients are, this is more common in women who are already having predisposing factors. And these are the women who are likely to have more complications. 25% of them may land up in an early pregnancy loss. So another entity I already told you is a pregnancy of an unknown location where pregnancy test is positive, but there is no intrauterine or ectopic pregnancy on ultrasound. So if the patient is stable, just continue to monitor her and keep searching for the pregnancy where it is. And by measuring beta HCG regularly, you know. If the beta HCG is increasing, then definitely repeat ultrasound to see where the pregnancy sac is. If the beta HCG is dropping, wherever it is, that means the fetus is not going to be live, then you can be cool. But also look out for the warning signs and symptoms of ectopic pregnancy, which can be there whenever you do not find where the pregnancy is. Another entity which I would like to introduce is a heterotopic pregnancy, which is rare, 1 in 30,000. This is usually commonly seen when the women go for IVFs and artificial reproductive treatments. So here what happens, heterotopic pregnancy means there is more than one pregnancy. One can be inside the cavity, one is outside the, maybe an ectopic. So in such cases, you keep the intrauterine one, you only tackle the extrauterine. If you don't know, once you see an intrauterine sac and forget about the possibility of heterotopic, you may land up in a patient who has ruptured or ectopic and complications. And another is the connual pregnancy, where the sac can be seen in the one extreme corner of the uterus, which is likely to may rupture in a later date. So that is a major complication. Also, if you are not sure, you can also make use of MRI or a transabdominal scan. And it is very important that you know the antibody RH, the blood grouping and RH typing. Then in an ectopic, coming to ectopic pregnancy, the diagnosis is ultrasonography. So at a certain level, let's say 2000 international units per liter, when the beta HCG comes to that level, you have to see a pregnancy sac inside the uterus. So if you are not finding, search. Where is that? The max possibility is it is in the tube. So sometimes you may pick up a tubal pregnancy. Sometimes in the early days it might be different. It may be missed. But if the beta HCG levels are high enough and you did not find an ectopic pregnancy or an intrauterine pregnancy, then there is possibility of an ectopic pregnancy somewhere, and beware of it. And continuously monitor for her hemodynamic status so that she will not land up in rupture. Then there is also a possibility of a cervical pregnancy, that is pregnancy which gets implanted in the cervix, which can land up in severe painless profuse vaginal bleeding. So leading to profuse bleeding and very difficult to manage a cervical pregnancy too. Then when coming to miscarriages, you have a spontaneous as well as induced. Induced miscarriages, we are not bothered because it is a medical termination by choice. So we are not we have to plan accordingly and see that she will not have any bleeding. So in a normal miscarriage, if it is a spontaneous miscarriage, again there can be, based on the history, based on the ultrasonography and your clinical findings, you have a whole range. You have a healthy pregnancy, then this pregnancy starts to be, no fetus is seen, or what we call as anembryonic pregnancy or a fetal death, IUD, then you call it as a missed miscarriage. Then slowly, patient, if she goes into a threatened miscarriage, some amount of pain and bleeding starts. Then there will be the cervix which is opening, but the products are still inside, then you call it as an inevitable. Then either for later on, inevitable gets converts into incomplete, means partially the products are retained, partially they are expelled. or everything can get expelled and the cavity becomes evacuated completely. That is what we call as a complete miscarriage. So now and then slowly it involutes and comes back to its normal status. So this is what happens if you, may happen if you leave a miscarriage alone. But then there can be, it can stop at any point. It can stop at threatened, it can stop at inevitable, it can stop at incomplete. And patient may, especially when it is incomplete, patient may bleed profusely. Then an active intervention is needed. So depending on the patient's condition as well as the amount of bleeding, you have to take a call. So threatened early pregnancy loss means that it is only threatening. It is not mandatory that it will land up in a pregnancy loss. So first you look for the bleeding, then you look into the ultrasound to see if the fetus is alive or not. If if there is no viability, depending on the amount of bleeding, you repeat ultrasound or plan for removing the fetus. Then if it is, what are the treatments available? Either expectant management and reassurance. You can use supportive treatment like progestins, and there are no effective interventions really which can give you a very good outcome. But most of these pregnancies, more than 90% of threatened miscarriages can continue in the pregnancy. Even bed rest is not going to help. So please don't ask for leave and take absolute bed rest. So what you are doing is just expectant management. Fetus is viable. We are happy. We are waiting for 1 week, 2 weeks with adequate reassurance. Maybe progestins, which doubt the role is not very definitive, but then and follow it up. Then either they have a continue with the pregnancy or they might convert into complete miscarriages. If they continue with the pregnancy, they have a higher risk of early pregnancy loss, or not only early pregnancy loss, but preterm birth, premature rupture, fetal growth restriction can also be there in these patients. It is much less when it is very light and early, only bleeding is in the very early weeks. So if this is in case of a live fetus, if you find a fetus which is not having a heartbeat, then you go for a outpatient treatment or surgical treatment. Outpatient, you again have an expected management, medical management, procedural management, or you do in the surgical management like MVA or DNC in the OR under general anesthesia. So medical management, more effective. The most commonly one is giving 200 milligrams of oral mifepristone, and 24 to 36 hours later we give 800 micrograms of vaginally administered misoprostol. There is cramping, a vaginal bleed, nausea, diarrhea can be there. You also have to be sure of adverse drug reactions for these drugs and their side effects. So you have to be known before you, and have consent, appropriate consent and education is mandatory. Surgical management is by aspiration. You can do it by vacuum aspiration. That is the best. Sharp curettage will cause Asherman syndrome, adhesions and Asherman syndrome at a later time. So we prefer a vacuum aspiration. If the patient is coming to you with incomplete abortion, you can wait for it to convert into complete abortion by itself spontaneously, that is expected management. Or if the patient is bleeding and her vital signs are not good, she's looking pale and anemic, better to evacuate the retained products of conception under anesthesia. If it is a complete early pregnancy loss, if you had a previous pregnancy which has shown that there is a, ultrasound shows that there was a pregnancy, now it is showing an empty cavity, or if you can pick up the products and see them by clinical examination or under microscope, you can be sure that it is a complete early pregnancy loss. And there is going to be a fall in beta-HCG. So septic abortion, what are the symptoms and signs you have already looked into? So basically when it comes to nursing care, you have to document the amount and character of bleeding, and anything the patient passes like clots or tissue, you have to save it and then send it for histopathological examination. You keep track of the perineal pad count and how much of the pad is getting wet. Monitor her vital signs, take temperature, report if there is any increase in bleeding. If the patient is bleeding actively, you have to resuscitate her immediately as well as keep her NPO because she might be surgically managed. And importantly, it doesn't end with that. You have to continue with the post-abortion counseling and emotional care. See, any woman who loses a pregnancy spontaneously, whether it's early pregnancy loss or ectopic, they are likely to have a lot of grief. So support and encouraging the grieving process, not only of the individual, but the whole family is very important, which the nurses can deliver to a very good extent. Then if the patient is Rh incompatible, that means she is Rh negative and husband is positive, then you have to give Rh immunoglobulin. This has to be kept in mind. Otherwise, her future pregnancies are also likely to get affected. So if it is an ectopic pregnancy, you have already seen the previous speaker has told you all about the risk factors. So how do you manage? Again, you have an expectant management, you have medical management with methotrexate or surgical intervention. So giving intramuscular methotrexate, and then you have to closely monitor, because once you give methotrexate, then the patient might respond, or the ectopic might grow and get ruptured and land up in a rupture of the ectopic with torrential intra-abdominal bleed. So you have to continuously admit her in the hospital and monitor her. And suppose if the beta hCG levels are falling, then you know she is responding. If she develops anything like a ruptured ectopic or beta hCG levels are not falling, then you have a surgical treatment option like salpingectomy or salpingostomy. Ostomy means you just give a nick on the tube and suck out the contents, pregnancy contents. Salpingectomy is removing the tube. It can be done with laparoscopy or by laparotomy. And it is your job to see that the patient is fit and the post-operative care and pre-operative care as per the protocol. So these are the different types of, you can see a fimbrial ectopic. Here you can see an ampullary ectopic. Then here you can see this is in the ischemial region. The ectopic is in the ischemial region, and here it is in the interstitial portion. So these are the different types of ectopics, but basically you can see the ruptured ectopic, or this is a tubal abortion. Since it's at the fimbria, it bleeds slowly, trickles into the peritoneal cavity. Otherwise, if it is anywhere in the ischemial region, it just ruptures because it is still quite narrow, and then this is going to rupture and she'll bleed torrentially into the peritoneal cavity. Then the nursing care is the patient. You have to monitor for the patient's blood pressure, pulse, and which might indicate that there is a hypovolemic shock, and amount of vaginal bleeding. Rh negative patients, I already told you, give immunoglobulins. Controlling and monitoring of pain levels, that is very important. And if surgery is done, you have to continue post-operative care like monitoring vital signs, oxygen saturation, intake output, and lab results. And most importantly, emotional support is very, very important. Then again, you have also seen that there is something known as a gestational trophoblastic disease. It can happen in 0.1% of the cases of early pregnancy bleeds. And here you have to confirm by the history, a history of passing vascular molar-like tissue, hyperemesis, do an ultrasound, you can see a snowstorm-like appearance and inside the uterine cavity. The best treatment is suction evacuation and histopathology. You have to follow it up by declining hCG. Here the monitoring levels is declining beta hCG levels. If the beta hCG levels are increasing, it means that gestational trophoblastic disease, which is benign, is getting converted into choriocarcinoma, which is a malignancy. And you have to give adequate contraceptive advice for this group of women. So this is how you follow up a case of gestational trophoblastic disease. Then for completion, we also need to know that there are cervical lesions which have to be excluded. When nothing you can see, little bleeding, patient says I have very little bleeding or postcoital bleeding, or if she says a foul smelling discharge, put a speculum, see if there is something like a cervical erosion or a cervical polyp, or if there is any growth on the cervix, which are all the possibilities when there are cervical lesions which can lead to bleeding, especially postcoital bleeding happens with these type of lesions. Sometimes, rarely, you can even see fibroids complicating pregnancy, and these fibroids, especially if the placenta is close by, then they can also cause a continuous irritating sort of bleeding. Then you also have what we call as a cesarean scar ectopic. Previously, a cesarean scar was done, and the pregnancy sits on the ectopic, pregnancy sits on the scar, which is going to be very, very dangerous and may need to be terminated. Now, with increasing cesarean sections, this is a scary possibility. So, coming to the algorithm, how to diagnose and manage. If the patient is in the early weeks, just take the history, do a physical examination, look for peritoneal signs or hemodynamic instability, then resuscitate and consider immediate surgical intervention. If it is non-obstetric causes, you have to find out the cause and then treat it accordingly. If you can see the products coming out through the cervix, then it is an incomplete abortion, and either you wait for it to completely get expelled or remove it surgically. If the patient is stable, nothing is seen, then you have to do a TVS and obtain beta HCG. If it is like an ectopic, you have to go ahead. If it can be a viable intrauterine pregnancy that is threatened miscarriage, you have to follow up with expectant management and repeat your ultrasound after a week or two. If it is a non-viable intrauterine pregnancy, then again you have to talk to the patient and sympathize with them, and then go ahead with whatever their treatment, whether they want to go for expectant or non-expectant. If you're not sure of the viability, bleeding is not very heavy, repeat ultrasound after 2 weeks and continue monitoring with HCG. If you think it's a pregnancy of unknown location, nothing can be found, then it is very important that you, if it is not a complete abortion, to be very carefully monitoring this type of patient. Then, if it is a miscarriage, reassure, treat the modality, psychosocial support. So, viable intrauterine pregnancy, bleeding is persistent, rule out other cervical causes. If it's an ectopic, you can either treat conservatively, medically, or surgically. If it is molar, you have to evacuate it, follow up with beta HCG levels to see if they're falling, or if they're increasing, you have to suspect malignancy, and then give contraception as well as psychosocial support. So, basically, I think all these things are a part of nursing care: education, updating, empathy, monitoring, dispensing the drugs and keeping track of the drugs, documenting, very important, including consent for every procedure we do. Patient education is, again, I think it is by sympathy, and also they look at you for further clarification of their queries and follow-up and contraception. These are the important things which I feel a nurse can do all this if you are committed, and if you want to monitor if you are into the obstetric nursing. So sometimes we can't see why normal isn't normal. So that's what I would like to conclude with. And thank you all for your patient listening. With this, we come to the end of my presentation.
Thank you so much, ma'am. That was really a very valuable information.
Yeah.
And we have been seeing so many comments saying that very good information has been received. Really, thank you so much, ma'am.
My pleasure. Thank you.
There were few questions posted in the chat box, ma'am.
Yeah.
I'd like you to answer with them, ma'am.
Yeah.
So one of the question is, what is the drug of choice for antenatal mother with COVID positive?
Oh, you're coming to COVID. You have no questions on that topic, I said.
Because this is the pandemic going on, everyone is much interested in COVID, ma'am.
No issues, but there's no questions. First, let us take up the questions on early pregnancy bleeding, then we'll move to the others.
Yes, ma'am. So they were asking, a question posted was, how many months should HCG be repeated in ectopic pregnancy?
Months, sir?
Yes, ma'am.
No.
When can we repeat the HCG test?
No, no. If you know it is an ectopic pregnancy, don't wait. You have to do something. Either if it is very early pregnancy, you have to just follow it up by ultrasound, or if the only thing when you're doing following up you're doing beta HCG is when you're not sure that there is a ectopic pregnancy for sure, and you're following it up to see if this is spontaneously it will regress or not in the very early weeks. After that, the follow-up is only by ultrasound. You have to search where the ectopic is. If the ectopic is found, then immediately you treat it. In the early weeks, we treat with medical management, that is methotrexate. That is when there is a certain criteria below which we can use a medical methotrexate. And beyond that, it is only surgical management, preferably laparoscopy if you can do it. But the follow-up is mostly for when you are not sure of the size of the gestational sac. Sometimes they give you a scan report. I am finding a small sac-like structure, but I cannot see an embryo, nor can I see the heartbeat. But you can also not find a intrauterine pregnancy. Then your HCG is positive. Then you are confused, isn't it? Then only you follow it up with, that is one sort of scenario where you follow it up with repeated beta HCG. I hope I'm clear.
Yes, ma'am.
Yes.
There is another question. For scar pregnancy, do the mother will she be able to continue the pregnancy?
No, usually we do not, because the scar pregnancy is that scar is very thin, right? And imagine a pregnancy sitting on the scar. So what happens is, if this will erode into the uterine, through the uterine wall, it goes even into the bladder, whatever it is, and causes rupture and severe bleeding. So even for treating it surgically also, it's very bleeding is quite heavy in such cases. So we either manage it again similar way like any ectopic, either by by methotrexate or by evacuation. If you are evacuating and resecting, you may have to even resect the previous scar. The worst scenario is where there will be profuse bleeding when you try to evacuate it by simple DNC or aspiration. So this is quite a dangerous thing to find, which we are finding more frequently in the present scenario with so many patients coming with the previous cesarean section. So there is no possibility of continuing with a previous cesarean scar and a scar ectopic pregnancy.
Thank you
because
so
the
much.
placenta gets adherent to that, and it erodes through that, and leads to something what we call as, here already the endometrium, the myometrium and everything is thinned out and heals by fibrosis. So your placenta lands up in what we call as a placenta accreta. That is a dangerous complication, right?
Okay. Yes, ma'am. Can I ask you the questions on COVID, ma'am?
Yeah, sure. Yeah, are we done with bleeding?
Yes, ma'am.
Excuse me, ma'am. I have a doubt. Excuse me, ma'am.
Yeah, sure.
I am Archana, ma'am. Ma'am, are there any evidences of Cullen sign in ectopic pregnancy? And if at all we observe a patient with Cullen sign, what is the immediate management we can do, ma'am? Because that is a sign of already ruptured ectopic. So as a nurse, what immediate action we can take when we observe Cullen sign, ma'am?
Correct. See, this Cullen sign is something which has been described much long ago, when we did not have an ultrasonography, where they never used to know whether the uterus has ruptured or not. I mean, the ectopic has ruptured or not, and the whole abdomen would be full of this blood, and then the Cullen was positive. So that we nowadays, in the present scenario, we don't allow it to go to that stage. If the patient who is coming to you with a ruptured ectopic, as early as possible you diagnose. So patient comes to you with a history of, I have missed my period, or I had very scanty menstruation, or I had a normal period, but from a few days, I'm feeling giddiness, that is syncopal, on right shoulder pain. These are all signs that there is intra-abdominal hemorrhage, and then she'll give you a feeling that she has acute abdominal pain followed by chronic irritating abdominal pain, because there is leak into the peritoneal cavity. So the first thing you would do is you confirm with the urine pregnancy test. If the pregnancy test is negative, still do not exclude, urine may not be sensitive enough, do not exclude an ectopic. Then you go for an ultrasound. Once you do an ultrasound, you will know if there is a fluid in the peritoneal cavity for sure. If there is fluid in the peritoneal cavity, we are going to operate. There is no other way. Ruptured ectopic, the only thing is you have to make the patient stable, arrange for blood for cross matching, and then take her up for surgery. So depends on your skill and depends upon the general condition of the patient whether you are going to go for a laparoscopy or a laparotomy. So sometimes laparoscopy suctioning out takes a long time, so some may prefer to do a laparotomy, but otherwise laparoscopy is always ideal. Okay, so color sign and doing a aspiration of from the pouch of Douglas, this is also not very I mean, we are not doing it in the present sign. That's our old time when we had when we didn't have a ultrasound so well defined.
Ma'am, actually, we have another doubt on endometriosis. Actually, we will giving. No, there's a bleeding. I mean, we have been. For example, like Dynogest is one tablet which has been given to for 2 to 3 months, and after 2 months or so, the bleeding resumes, no, ma'am, in a person with endometriosis. Suppose if the tablet is taken on the day of ovulation, unexpected, does it stop? Because it is progestin only hormone. Does it stop the
per se will not cause anovulation. It does not cause anovulation. But if you know that you want to continue with Dynogest, if you do not want to have a pregnancy, better take a combination. There are combination pills. Ethinyl estradiol with Dynogest is also available. So you may as well take the contraceptive pill if you are not planning for pregnancy. If you are planning for pregnancy, better go for a pregnancy rather than taking Dynogest and planning for pregnancy.
Okay, but it
doesn't. Excuse me, ma'am.
As such, no, ma'am. If it is taken unexpectedly, I mean.
If the pregnancy happens accidentally, because Dynogest does not completely suppress ovulation per se by itself, unless it is given in a as a combined pill, then you may land up with a pregnancy. Then again, it depends on the patient's choice of whether she wants to go with the pregnancy or not.
Okay, thank you so much.
And the studies are very not long term, so that we do not know the tetragenicity and all these are not adequately known.
Okay.
Because the drug is new. Drug is new, right?
Yeah. Thank you, ma'am.
So what happened to that COVID? Some COVID question?
Yes, ma'am. What is the drug of choice for antenatal mother with COVID positive?
What drug of choice? There is no drug of choice. You manage it as per non-pregnant women. See, the other day we had one patient. She came, she delivered, she died. As simple as that. There is no drug available. If you are looking at whether you can give hydroxychloroquine and all, hydroxychloroquine is not. We use it for pregnancy, malaria. So it doesn't have side effects. So, but then how much does a hydroxychloroquine help? We have no idea. And coming to steroids, yes, it can be given. Antiviral drugs we have been given, but I think if it is a COVID-19 positive woman, do not bother about the baby. Go ahead and treat her as if she is non-pregnant itself. Maybe steroids, maybe whatever, depending upon her oxygen saturation and her general condition. When you have to do all these D-dimers, ferritin levels, see which level she is, and then go accordingly. As per the studies, now it has not found, hasn't found to cross the placenta, except that there are sporadic studies where it has shown that the fetus also showed, the newborn has been positive in spite of, in spite of what we have understood till now. So everything is a big query. We have no idea exactly about, I have seen, although they say pregnancy with COVID is not worse than non-pregnancy, I personally think it is really a very dangerous problem to have. So I tell all my antenatal patients, try to not to even come to OPD unless it is we have a different antenatal care. We don't need to see them so frequently. So try to make online consultations and minimize the exposure. Don't take it lightly. And there is no drug of choice. There is not a single drug. Even in the non-pregnant people. So where is the question of having a pregnancy with a specific drug?
Okay, ma'am. Thank you so much, ma'am.
Yeah.
Thank you so much for explaining and answering all the questions, ma'am.
So are we done?
Yes, ma'am.
Okay. Thank you all. All the best. Good luck to you all, and you're continuing with the seminar, or is it done?
Yes, ma'am. We are continuing. We have one more speaker.
Okay.
Yes, ma'am.
Okay, then have a very pleasant meeting, and thank you all for inviting me once again.
Thank you so much, ma'am.
Bye. See you all.
Bye, ma'am. Bye. So now it's time to know the role of nurse during the bleeding and also for treating COVID patients. Now today we have with us Miss Irene, registered nurse from USA with 8 years of experience in healthcare, and she has done her master's in nursing in obstetrics and gynecology. Ma'am has experience in ER, ICU, telemetry, intermediate care unit, psychiatry, neuro, acute rehab, and many other specialties include mother and baby. Ma'am is also well versed with a course on COVID-19 preparedness, practices, and protecting healthcare workers, which was done in 2020. Ma'am has done so many certificate courses, and she has kept herself upfront and not compromising anywhere in providing care for the needy. We feel so privileged to have you with us, ma'am. I really appreciate you being present with us till this late time of night. Ma'am, I can't see your video. Can you please on your video and audio once?
Hello, can you hear me now?
Yeah, I can hear you. I can't see you.
Yeah, I'm going to turn it on. Give me 1 second. Hi.
Yeah. Hi. So ma'am is going to speak on role of midwife and care of the mother with COVID-19. Over to you, ma'am.
Yeah. Good morning, one and all. I thank you all for joining us for this webinar. First of all, I would like to thank the principal, Vasundhara ma'am, Jubilee ma'am, and also Harika for inviting me for this webinar. Let us go into our topic. Let me share my PPT. I also have shared the PPT in the chat, so if you would like to download it, please go ahead. Right. Can you? All right, so today we are discussing about role of nurse, midwife, and care of mother during pregnancy with COVID-19. I know this is a hot topic everywhere, especially in general public, but pertaining to maternal health, everybody is concerned about how to take care of pregnant women or women who are breastfeeding, and we all want to know what precautions to take, and we want to know if the COVID-19 is affecting the baby. So first, let us learn what maternal health is. We all know that it refers to the health of women during pregnancy, childbirth, and the postnatal period. Each stage should be a positive experience. It should ensure that the woman and baby reach their full potential for health and well-being. We want both of them to have a safe and healthy pregnancy, safe and healthy neonatal and postnatal period. Okay. Now let's see what the causes of maternal injury and death are. We have learned from our previous lectures in this webinar that maternal injury and death is caused by excessive blood loss, as you have seen in early pregnancy, or it might be through postpartum hemorrhage, and it might be also through infection, viral infection, bacterial, and also it might be during labor. When there is an obstructed labor, it might lead to death of the mother or the baby, sometimes both. And when they practice unsafe abortion, then that is also another cause for maternal injury or death. High blood pressure, and also anemia and malaria and heart disease. All these are causes of maternal injury and death. Let's see the global situation of the pregnancies, how many pregnancies and deliveries are there in this world. Go ahead. Yeah, most maternal deaths, they are preventable with timely management by a skilled health professional working in a supportive environment. Now, the healthcare professional means it means primarily a nurse and a doctor. So we play a very vital role in preventing the maternal deaths. About 140 million births take place every year, and the proportion attended by skilled health personnel has increased from 58% in 1990 to 81% in 2019. This is mostly due to larger numbers of births taking place at a health facility. Okay, this is only because the pregnancies or deliveries are conducted by educated healthcare professional, which is why we see that there are not much mortality rates or good progress in the pregnancies or deliveries. Go ahead. So most maternal, deaths from complications during pregnancy, childbirth and postnatal period have declined. They have declined by, sorry, I can't see your thing. They have declined by 38% in the last 2 decades, but at an average reduction of just under 3% per year, this pace of progress is far too slow. So yes, there is a decline in the complications during pregnancy, childbirth, and postnatal period, but the progress of reducing this deaths is really very slow. Now let us see the role of midwife with early bleeding in pregnancy. As you have already seen, we have already learned from previous lecture by Dr. Krishna Kumari and also by Jubilee ma'am, the causes of early bleeding in pregnancy. Let us see what our role as a nurse, as a midwife is in taking care of a pregnant woman with early bleeding. Okay, so around 25% of women experience some vaginal bleeding in the first 12 weeks of pregnancy. The causes of first trimester bleeding, as you all know, are implantation bleeding. So implantation bleeding is it's nothing but when the woman is pregnant for the first time, when the fetus gets embedded into the uterus. That is the time that a mother or a woman can expect that she will have a slight or a light menstrual period. Okay, that is implantation bleeding. Coming to subchorionic hematoma, it is Dr. Krishna Kumari has really explained it well about this. She has also shown us some pictures of how the hematoma occurs. It is actually a collection of blood that forms between the developing pregnancy and the wall of the uterus. So in these cases, many pregnancies are normal even if there is a subchorionic hematoma. There's usually not a problem. I am one of the example for this. For me and my second pregnancy, I had the subchorionic hematoma, and I was sent for some referrals and more. I had more frequent obstetric checkups and also ultrasounds. So they were just trying to keep close monitoring of how my health was when I had this. But I didn't actually have any problem after that, and I did have a healthy baby later. So that is one of it must be a common scenario for most women, but it is, if they have it, they will have a normal pregnancy and a normal baby, nothing to worry about it. But they have to be continuously monitored by their obstetrician. Next is miscarriage. Miscarriage is nothing but spontaneous abortion. Well, I don't want to go much deep into this, but you already know what it means. The pregnant women who have this condition or miscarriage especially need a lot of emotional support. It's very it's very depressing, and not only for the mother but also for the family. So emotional support is very important during this time. Ectopic pregnancy. Now, ectopic pregnancy, it means a pregnancy that occurs outside the uterus. It is primarily the fallopian tubes. All right. I do not want to go deep into that again. We all know what that means. Next slide, please. So this one, can you go to the next slide, please? No, the one before that? Yeah. All right. Now, how can we, as a midwife, take care of a woman with early bleeding in pregnancy? First is it is our normal thing. What we do is we first do a history and physical examination. We take the history of the mother. We have to take her gestational age, her past obstetric history, her medical history, and also you should also be asking the characteristics of bleeding, that she has any associated symptoms, and the course of the current pregnancy. You have to ask her at what trimester she's in, and also if she has had any complications in pregnancies before. And coming to the physical examination. Physical examination, we all know as nurses, we have to inspect, palpate, auscultate, and these are the vital things that we do. So what do you inspect for? You inspect the vaginal vault for the presence and amount of blood. And visualization of the cervix, we have to visualize the cervix. I know in India, we as nurses, we don't do in India, we do not do examination ourselves, because it is mostly the obstetrician or the doctor who does it. But that is one of the things that we can do if we are highly trained in that matter. And next is you palpate the size of the cervix, the size of the uterus. You can only auscultate the heartbeat after 10 to 12 weeks of gestation. So after 10 to 12 weeks, when you auscultate, you can see if the fetus is alive or not. That is the first thing that you can do. The second thing is assessing the need for and providing urgent care. So in this, we have to see the need for providing the urgent care. That is when there is an excessive bleeding, like when the mother is losing a lot of blood through blood. You have to assess, have to ask her how many pads she's been using, or if how much amount of blood she's losing. All these are things that we have to first assess. And then usually at this stage, the signs and symptoms of hypovolemia or low blood pressure, changes in blood pressure are not usually visible, because usually hypovolemia or changes in blood pressure occurs when there is a 10 to 15% blood volume that is lost. So maybe you wouldn't find those at an early stage. So first thing you might have to do is the doctor might ask the nurse to send for a CBC, that is a complete blood count. And next is the doctor would order some replacement of electrolytes by ordering for IV fluids, and also sometimes maybe blood products. If the if she's losing a lot of blood, she might need a blood transfusion. All right. And sometimes in rare cases, or if the pregnancy is not viable, if the fetus is not viable, or if she's as an inevitable inevitable bleeding, then she will have to go through surgery or DNC in early stages. All right, that is the second one. And the third one, as Dr. Krishna Kumari has already spoken about, RHO immunoglobulin. So this is the RH rhesus immunization that you give to a RH negative mother. Okay, a mother who should be given this intramuscularly 48 to 72 hours after having the onset of bleeding. Okay, this is, if it is before 12 weeks of pregnancy, the dosage is 50 milligrams. If it is after 12 weeks, it is 300 milligrams. All right. So as a nurse, we should keep that in mind and check if mother is RH negative, because as we know, it is high risk for next pregnancies if this immunoglobulin is not given. The fourth one is methods thought to prevent miscarriage. So these were methods that in the olden days were thought will prevent miscarriage. Like when you have a bleeding in the olden days, they used to say, oh, you have to take bed rest, you have to sleep, don't go anywhere, don't do anything. That was one of the misconception, but it is not much needed. You can actually do your normal daily activity, but not in excess. You shouldn't stress yourself. And sometimes they used to say avoid intercourse or use progesterone supplements. Well, these have no proven benefits, so we don't know if it is true or not. The last thing that we do during these emergencies are consultation, collaboration, and referral. Like I said, in my case, when I had this chorionic hematoma, I had to go to a specialist, radiologist who was specialized in high-risk pregnancies. So I had to go to her, and she collaborated with the obstetrician, and they together took care of me during my pregnancy. So that is how it works out, that is our role as a midwife during early pregnancies. So next I'm going to go to statistics of COVID-19. So this is the statistics. I don't know if I can share this. I will try to share one thing. Let me check if I can do this. Can you see my screen? Harika?
No, ma'am. Like only you are visible.
All right, so that's all right. I had a few videos, but that's fine. So let's go back to our PPT. Can I have my PPT back, please? All right, so coming to statistics. So a surveillance was conducted between January 22nd to June 7th. As part of COVID-19 surveillance, CDC received reports of 326,335 women of reproductive age, that is between 15 to 44 years, who had positively tested for COVID-19. So they had done a survey of these women. So in these findings, it suggested that women of reproductive age with COVID-19, pregnant women are more likely to be hospitalized. That was one thing. They were more likely to be hospitalized. The second thing is they had increased risk of ICU admission. All right, and also they were more likely to be on mechanical ventilators. So these are compared to the non-pregnant women who had COVID-19. But the good thing is it was not associated with increased risk of mortality. There was no mortality risk for pregnant women. They only had increased risk of hospitalization, ICU admission, and being on a ventilator. So to reduce this occurrence of severe illness from COVID-19, pregnant women should be counseled about the potential risk for severe illness from COVID-19, and measures to prevent infections from SARS-CoV-2 should be emphasized for pregnant women and their families. All right. Next slide, please. Did we skip a slide? Can you go back, please? Can you go back one slide, please?
I have done it like it's a bit
I can
slow.
see the slide, but can you see the slide?
1 minute. Yeah.
All right. Oh. All right. Now let's see what we need to do when there is a pregnant woman with COVID-19. Before I start telling what we need to do, I want to tell an example. I was going to show you a video. In that video, there was this doctor, obstetrician, who was interviewed on the CDC statistics that I have just explained to you. It seems they found a mom who was tested negative for the virus in Mexico. Then she gave a birth to triplets who were all tested positive. So according to the CDC, since the risk for pregnant women is only hospitalization and ICU admission and ventilator, being on a ventilator, but there is no risk of vertical transmission. So the doctors said that must be a case where there may be a possibility of false positive. We do not know. Maybe it was a false positive, and it might be transmitted after the baby was born, but she said rarely there is a vertical transmission. Vertical transmission is transmitting the virus from the mother to the baby. So there is a rare chance of transmitting the virus from the mother to the baby. Okay, we will see what precautions we need to take later. First thing is, let's see what actions we need to take during pregnancy. So first thing that you need to do is you never miss an appointment. You have to tell the pregnant woman not to miss her appointments during pregnancy. Now we have seen that telemedicine is being used widely in all over the world because of COVID-19, and it is a great benefit for especially the pregnant women, so they can protect themselves as well as also get obstetric care during this difficult times. So they should not skip their appointments, and also they should limit their interactions. They should take the precautions they need to take to prevent COVID-19. As we all know, it is social distancing. For pregnant women, they have to double the social distancing. We have to be 6 feet apart as per the WHO, but they have to be at least 12 feet apart. That is to keep themselves safe and also the baby safe. And also they have to take other precautions like wearing a mask, washing their hands. That's all the usual things that we are doing during this time. So that's some precautions that they need to take. And also they should always have monthly supply of the medication that they need to take, like their iron supplements, multivitamins, or whatever other prescriptions or medications that they're taking. They should always have it in hand. All right, but they should always, if they are in doubt of themselves or they're scared of their baby, they should always talk to their healthcare provider, their obstetrician, or the doctor or their nurse, and they should clarify any questions they have. But if in case there is any medical emergency, they should always call the hospital which is nearest to them and try to go there as soon as possible, and also inform their own doctor about what is going on. The second one is, as we all know, the vaccine for COVID-19 has not been found yet. There are still trials going on, but other vaccines that the pregnant woman should take are the flu vaccine and Tdap. Tdap is nothing but DTP, the diphtheria, tetanus, and pertussis vaccine that we take during pregnancy. And flu vaccine is one thing that they take in the US. So your regular vaccines you just take as recommended. Coming to the prenatal and postpartum care, I told you already, do not miss doctor's appointment. Always make sure you have these telemedicine visits, and if you have any doubts, always keep in touch with your doctor through WhatsApp. Or I heard that the doctors in India are trying to use WhatsApp as a medium to do the telemedicine calls. So that is one good medium for the mothers to get 24/7 care. And we have the next thing in prenatal postpartum care is delivering at a healthcare facility under the supervision of trained healthcare personnel. This is very important, especially during COVID time, because the risk of transmission there is for this COVID-19. So it is most recommended for the pregnant woman to deliver at a hospital. All right. So this is about some pregnancy consideration. Now, how can you protect yourself if you are pregnant? Wash your hands frequently. Put space between yourself and others. Avoid touching your eyes, nose, and mouth. And if you are coughing or sneezing, cough it into a bent elbow or a tissue. Okay, but if you have any fever, cough, or difficulty breathing, seek care early, call beforehand, and follow medical advice. So what do you do? Before, during, and after childbirth, all women have the right to high quality care. This includes antenatal and intrapartum, newborn, postnatal, and mental health. All these they have a right to, so we have to give them all the care required in all these stages. All women have the right to safe and positive childbirth experience, whether or not they have a confirmed COVID-19 infection. So just because a mother is COVID-19, we cannot have any stigma between her and another woman who's not COVID positive. We have to give them the respect and dignity that they need. We have to clearly communicate, and we should be a companion of choice. We have to be more compassionate during those times. We also have to give pain relief strategies. If they are in pain, we have to ask the doctor for any pain medication that they can give for the pregnant women. And mobility in labor where possible and birth position of choice. Whenever in labor, there are different positions, as we know. So during this time, even though they are COVID-19, they can give birth in different birth positions of their choice. Next slide, please. Can you go to the next slide, please? Can you go to the next slide, please, Harika? Harika? Yeah. So quality antenatal care. It will encourage women to seek skilled care at childbirth. It reduces stillbirths, childbirth complications, and newborn deaths. It also helps women get care and counseling for HIV, malaria, TB, and other conditions. Okay, so quality antenatal care should be available for all women to ensure a positive pregnancy experience. The next slide, please. So, throughout pregnancy, all women should have 8 contacts with a healthcare provider. Okay, these can happen in settings such as health facilities or community outreach services. Health systems should ensure that all providers are empowered and equipped with necessary skills and supplies. For in this case, we should have enough supplies for protective equipment, our personal protective equipment, that is masks, gloves, and the gowns that we need to wear, and also N95 masks. So we have to protect ourselves as well as the mothers, as well as mothers who are not COVID positive. We do not want to transmit the COVID virus from one mother to another mother who does not have it. So we have to be really cautious. So let's see about the newborns born to mothers with suspected or confirmed COVID-19. How do we care for these newborns? So the first thing is CDC, that is Center for Disease Control. It recognizes that the ideal setting for the care of a healthy full-term newborn during the birth hospitalization is within the mother's room. So first thing is the newborn should be in the mother's room. You do not need to separate them. All right. The second one is temporary separation of the newborn from a mother with suspected or confirmed COVID-19 should be considered to reduce the risk of spreading the virus.
Hello.
Yes? Hello?
Hello.
Yes? Is somebody speaking to me?
Ma'am, kindly continue.
All right, okay. So temporary separation is done only when, you know, it is a very high risk case, when sometimes the mother wishes the baby to be away from her. So in such cases, she can the baby can be sent to a nursery and be cared for. The third thing that we see is we have to, the third one is the healthy caregiver. If possible, we can send the newborn to a healthy caregiver, maybe the mother's parents or father's parents or their siblings, whoever is a healthy caregiver. We can send the baby of suspected or confirmed COVID-19, we can temporarily separate them to by giving them to a healthy caregiver. The next thing, before I go to the next one, I just wanted to put on this. Harika, are you able to copy this the URL and show the video?
Like it is taking time to download and all.
All right. Okay, then that's fine. So, okay, let's talk about COVID-19 and breastfeeding. After I complete this, I will share my experience with a mother who had COVID-19. So the breast milk, it provides protection against many illnesses and is the best source of nutrition for most infants. We do not know for sure if mothers with COVID-19 can spread the virus to babies in their breast milk, but the limited data available suggests this is not likely. Can you go to the next slide, please? Okay, so close contact and early exclusive breastfeeding helps a baby to thrive. A woman with COVID-19 should be supported to breastfeed safely, hold her newborn skin to skin, and share a room with her baby. So the woman with COVID-19 can breastfeed. That is what we are trying to emphasize. Breastfeeding is really beneficial to the baby. And also, when a woman wants to breastfeed, they should practice respiratory hygiene by wearing a mask. They should wash hands before and after touching the baby and routinely clean and disinfect surfaces. They should also clean their breast and nipple area before they feed the baby. So if a woman with COVID-19 is too unwell to breastfeed, she can be supported to safely provide her baby with breast milk in other ways, like she can express her milk. It may be manual expression or breast pump. She can use a breast pump to keep the milk coming. The next one is relactation. Relactation is when if a mother has started feeding and suddenly stopped because of some because of a situation or some complication or something, she's unable to get milk, so she stopped. So in that time, or even if a mother has never breastfed as soon as after birth, she can always try to start feeding again by bringing the baby to the breast and also increasing the breastfeeding time, because sucking from the baby brings the milk supply. So she has to do this more frequently, at least dozen times a day, even at night, to keep the milk coming out. So that is relactation. And donor human milk. There are some donors who have excessive supply or who would like to donate their milk to others. So in such cases, the mother can use that milk too. Okay. Now, if the mother has COVID-19 and chooses to express breast milk, what should she do? First is she should use a dedicated breast pump. It should not be shared. You shouldn't share the breast pump with anybody. It should be exclusively just for the mother. She should wear a face covering, wash her hands with soap and water for at least 20 seconds before touching the pump or bottle parts and before expressing breast milk. This is the same thing that she should follow even if she exclusively breastfeeds. And the next thing is she should follow recommendations for proper pump cleaning after each use. She should clean all parts that come into contact with breast milk if possible. Expressed breast milk should be fed to the infant by a healthy caregiver who does not have COVID-19 and is not at risk of for severe illness from COVID-19 and is living in the same house. For us, in our case, it might be the mothers of the pregnant woman or mothers of the baby's father. So whoever is an immediate family member and is not exposed to COVID-19 are always welcome to help feed the baby. Okay, now in COVID-19, what is our role? As a midwife, how can you take care of a pregnant woman? So first thing that we do is we have to maintain appropriate isolation of pregnant patients who have suspected or confirmed COVID-19. We all know what appropriate isolation means. If they are COVID-19, we have to separate them. In our hospital, we use negative air pressure rooms. The rooms have negative air pressure in them so that the virus doesn't spread from the room to the outside of the room into the hallway or into the other rooms. So you should use such kind of rooms to isolate the pregnant patients or anyone with COVID-19 for that matter. And basic and refresher training for all healthcare personnel on those units to include correct adherence to infection control practices. So the healthcare personnel, all the nurses, anybody who comes in, the lab technicians, anybody who comes in contact with the patient, it will be even the nursing aides, the DIAs, whoever help to take care of the patient, they should have a good training of adhering to the infection control practices so they can properly wear their personal protective equipment and they know how to use and handle it and how to discard it. So they should have training in this. And PPE use and handling. Appropriate PPE supplies should be positioned at all points of care. The hospital should make sure that PPE equipment is available right outside the isolation rooms so that we are not like going around to look for it. It should be within reach. So these are some things that we have discussed for COVID-19 and breastfeeding. So when I come to my experience, I had a COVID-19 mother who was she was positive. So she during her I think labor, she had a complication. So they I remember she had a normal delivery, but because of COVID-19, she was suffering with shortness of breath. She had nausea, diarrhea. The baby had to be separated from her. So as soon as the baby was born, the mother also chose to keep the baby separate. So that's why it is always important to ask the wishes of the mother whether to keep the baby with the mother or in a separate room or in the nursery. So during her hospital stay, the baby was in a nursery, and then since the father was also COVID positive, the baby was sent home with the mother's sister. So the baby was home, the mother's sister was negative, and she was taking care of the baby. And while the mother was here, she had these symptoms. She only required oxygenation. As long as she was there, she was also receiving the steroids. And at that point of time, there was also she was also on antivirals. Right now here we are using remdesivir antivirals for treating the COVID patients. Previously hydroxychloroquine and chloroquine were used, but since they were not proven to show any benefits, I think the antivirals and steroids are being used. So she was receiving these antivirals, which is why she was asked not to give her breast milk to the baby. That was only the reason that hindered her from giving the breast milk. Otherwise, a COVID-19 mother can give milk to the baby if she's not on any COVID-19 medications. All right, but if she's not giving milk to the mother baby, she should always express the milk out, because if she's getting increased milk supply, it is not good for the milk to stay in the breast. It causes infection, engorgement, so we don't want that. So you still have to encourage her to use the breast pump or express with the hand. So that was one experience that I had, and but I have eventually seen that she got better and she had gone home to be with the baby. In some cases I've also seen that there some COVID-19 patients received convalescent plasma. While it was beneficial, well, I don't know if you know what convalescent plasma is. This plasma is taken from the patients who had COVID-19 and recovered. The antibodies that they have after they are symptom-free and recovered after, I think, 28 days after they have COVID-19, they have to be tested positive for COVID-19, symptom-free, and they have to have the antibodies. They use such plasma of those patients to give treatment to patients who are having complications with COVID-19. So it helps, especially when they are lacking oxygen, or they're suffering with shortness of breath, or being in ICU, getting a ventilator. Most of them are receiving dialysis. In such cases, it's really helpful. So those are some of the treatments that are being used in our hospital. Okay, now going to considerations for inpatient obstetric healthcare settings. Let's see what the pre-hospital considerations are. Well, here in the US, what they suggest is, they suggest that the mother call beforehand. Like here, the mother is always in touch with her obstetrician, and they plan the care, they plan the delivery. So they have to call the obstetrician as well as the delivery unit, the labor unit, before they come. So if they are COVID-19, the hospital personnel should make a room, isolation room available for them. So it is important for them to call beforehand. Okay, so that is one thing. And next is the other pre-hospital consideration for us as a healthcare team is we have to keep all the infection control equipment ready. All the PPEs should be made available to take care of the mother. The third one in the pre-hospital consideration is everybody taking care of this COVID-19 mother should know that she has the virus, so they can protect themselves and also prevent the risk of transmitting the virus from this mother to another mother. So that is very important. Now, during hospitalization, what can be done during hospitalization is pregnant women admitted with the COVID-19 and who develop the symptoms of COVID-19, they should be prioritized for testing. Now, testing is one thing that has become very valuable because of less testing kits. So they have to prioritize who to test and who not to test. So in our hospital, they make sure any pregnant woman who comes to deliver, irrespective of having symptoms or not, everybody is tested. Whoever is going into labor, they are tested priorly for COVID-19. So prioritize testing is one thing that we need. Next is testing of asymptomatic pregnant women at the discretion of the healthcare provider and facility. So no, I don't know if everybody is testing the asymptomatic pregnant woman. Like I said, our hospital does it, but not every hospital may follow it. So it is it depends upon every hospital and their equipment and their policies and protocols. The third one is the personnel should be correctly trained to take care of these pregnant women with COVID-19. The fourth one during hospitalization, the most important one is limit visitors. You have to limit the visitors. For us in our hospital, we have no visitors in any other floors. I work in emergency room, I work in ICU, I float to different floors as needed. So previously, before COVID-19, at least one a visitor or an attender was allowed. But now, because of COVID-19, visitors for pregnant women are allowed. That is only the partner. Only the partner is allowed into the labor room or to be with the baby after delivery, but none other than the partner. But the partner who comes is also screened by asking questions, and also their temperature is taken, and also they have to follow the social distancing, wearing the mask. Otherwise, it is not possible for them to stay with the mother. So that is one thing that we have to keep in mind, especially during labor, which is, I mean, that is an important time in India. We know that all our family, especially the pregnant woman's mother, or the the husband's mother, or they all want to be together to see the newborn, but we have to restrict all those visitors during this time. And coming to disposition is nothing but when the mother is being discharged. Is she being discharged with COVID-19 or without, or has the COVID-19 resolved by the time she's being discharged? So if she's clinically cleared to be sent home, then she can go home with COVID-19, and she has to still follow the precautions at home with the baby. So what can she do with the baby now? We have some scenarios where the mother has to take care of the baby. Sometimes she wouldn't have any healthy caregivers. Like, not everybody has a family, not everybody has someone to take care of her. So at that times, what can a mother do? How can she take care of the baby? She has, well, the baby can be with her. She still has to wear a mask at all times. She has to wash her hands. She can still breastfeed by cleaning her hands before and after, and cleaning her breast. And also, if ever she is having a cough or any other symptoms, that is when she'll need medical help. Otherwise, she's always welcome to take care of the baby by practicing all the precautions necessary. And the last thing that we need is, Well, we all know that COVID-19 causes stress to us. It is not only to the pregnant woman, it is to everybody. But, you know, we as nurses know what complications what complications we find in postpartum, which is first thing we see is postpartum depression. And in this crisis, in this pandemic, if a mother is alone and nobody is there to take care of her and the baby, it is very likely that she goes into a postpartum depression. So in such conditions, what can you do? How can you help the mother? So coping with stress during COVID-19, first thing we need to know what to do if mothers are sick and are concerned about COVID-19. As I told you, as we have discussed, you can explain to them all the information related to COVID-19, how they can take care of themselves and the baby, provide the emotional support and counseling they need. Also, point them to counselors who can counsel them and who can provide encouragement to them during this difficult times. So know where and how to get treatment and other support services and resources, including counseling or therapy. That is what I was talking about. Take care of their emotional health and take breaks from watching, reading, or listening to news stories. I know it is the news that we hear every day is draining. It is emotionally, it puts us down. So it's better to take breaks from that. Take care of your body, eat healthy, eat well, exercise. Even a pregnant woman or a breastfeeding woman, she should stay healthy by exercising, not strenuous exercise, but simple exercises, yoga, or any such sort of exercises. Make time to unwind. Unwind in the sense you have to make time for your family. Take away your if you're very distracted with this news, try to just turn it off, listen to some music, or just try to distract yourself and try to unwind yourself. Connect with others, connect with community or faith-based organizations. You can connect with friends, family. This is a time that we can try to get in touch with each other, and if we need support from our faith-based organizations, we can always reach out to our source of faith, our churches or temples or mosques, or wherever we go to, we have to find our to-go place. So this is some COVID-19 precautions and how you can take care of a pregnant woman and how you can take care of a newborn and breastfeeding woman. So thank you. Is that it? Does anyone have any questions?
Thank you so much, ma'am. We have got a very good and a very valuable information.
Thank you.
And it's already, the time is already up. So
yeah, I understand.
We would like to limit the question answers. Thank you so much for joining with us, ma'am. It's really a great pleasure to get the valuable information from you.
Thanks.
Yeah.
Okay.
So winding up the webinar, I would like to thank all the attendees who have attended, and especially the principals, the faculty, and all the staff who have attended the webinar. I'm grateful for all the speakers who have presented themselves, Nisha Clement ma'am, Krishna Kumari ma'am, and Irene ma'am, for taking their time and also explaining. I thank from my heart our principal ma'am, who has pushed us to conduct this webinar, and also our vice principal ma'am, and also our OBG team for the constant support and enthusiasm. And a special thanks to Apollo IT team who have helped and who have made this webinar a successful one. Thank you all. And regarding the feedback, we have shared the feedback link in the chat box. Kindly put in the feedback so that you'll be receiving your e-certificates within 1 week. Thank you all for joining.